Good afternoon, good morning, good evening, wherever you may be. And thank you for joining us today. We are talking about myelofibrosis, which is a myeloproliferative neoplasm. Typically on these webinars, we will get a lot of newly diagnosed patients. And so today we have with us Dr. John Mascarenhas from Mount Sinai in New York City. John specializes in MPNs, and he's going to share some updates and a few things with you about MPN or about MF. And then we have questions, and please send your questions along and we will ask those of John. He's with us for 1 hour, and so take advantage of this time with this wonderful specialist, and we will be with you. We will be right here to answer all your questions. John?
All right. Well, Anne, I always appreciate the opportunity to join you guys for these webinars and discussions about myelofibrosis. And I appreciate all the work you've done over many years and including me in that effort. And I always enjoy interacting with patients, whether it's in person or through these mechanisms. And I'm not using slides, so I'll just talk. Generally speaking, and as always, just remember everything I'm saying is general, and please don't act totally on what I'm saying without the input and approval of your treating physician. So I'll start from the basics of myelofibrosis, and I'll ask you to jump in and steer me in a direction if you feel like I'm going in the wrong direction. And I'll leave it to you to keep me roped in appropriately.
Sure.
So myelofibrosis is a malignancy. It's a cancer of the stem cells that arise in the bone marrow, and that's a question I often get. Is what is this that we're really talking about? Is it a cancer? Is it a disorder? Is it an inflammatory disease? And the answer is it's all of those things. And a lot of it is semantics, but words do matter. And the word cancer obviously holds a lot of weight. And I often look at it as, these are neoplasms, and neoplasm is just a fancy term for cancer. But they are also, and they historically have been called disorders because they do cause issues that go beyond often the cells themselves. And that's driven in large part by inflammation. These are inflammatory diseases. So they're all correct. And these words do matter, and I recognize that. And myelofibrosis is one of a number of these neoplasms that fall under a broad umbrella called myeloproliferative neoplasms, which means that in the bone marrow compartment there are myeloid and lymphoid cells, and these derive from the myeloid part of that bone marrow. Myelofibrosis is the one MPN that is by definition typified by fibrosis or scarring in the bone marrow. So that's where it gets the name myelo from white blood cells, fibrosis from the scarring in the bone marrow. I think it's important for patients to realize that scarring is not permanent. That scarring is dynamic, and there are opportunities to lead to regression and reduction in that fibrosis, and we'll hit on that today. So it's not a permanent, scarred, and irreversible process. It is reversible. Myelofibrosis is usually diagnosed in the 6th decade of life, but I have definitely met people in their 20s and even younger who have myelofibrosis, and it behaves very different in every patient I meet. And I've met a lot of patients over almost 20 years, and no two patients really look the same in terms of their history and their background, the way the disease is presenting, and the way the disease can behave during the clinical course. So there's a lot of heterogeneity, a lot of variability in the way the disease behaves. And that, of course, adds challenge to just grouping patients together and talking about patients, because no two patients are exactly alike, and they're not going to have the same shared experience. There will be some aspects that are shared, but everyone will go through their own journey. And I think it's important to sort of highlight that and emphasize that although you guys are not alone with the diagnosis of myelofibrosis, is that physicians have to be attuned to each individual patient, how they're behaving, and what are those goals of treatment for that patient, because even the goals may vary amongst patients and between different patients. So although I say it's typically you have to understand that that there isn't a monolithic myelofibrosis diagnosis. So although in the sixth decade of life, it can occur anytime, it can occur in any ethnic group, it can occur in any setting, whether it's urban, suburban, or in a rural environment. There's no clear cause of it. That often comes up, like what caused my myelofibrosis, and I would have to say for the majority of patients we see, we don't really know. There are definitely some environmental influences that likely increase the risk of developing myelofibrosis, so radiation exposure, prior chemotherapy, maybe benzenes and certain solvents. But the reality is for most people, those are just guesses if they've had those exposures, and we don't have a clear link for why they develop myelofibrosis. Another common question I get is, if I have myelofibrosis, are my kids going to get myelofibrosis? Are my grandkids at risk for it? How does it translate in terms of genetics? And is it a genetic disease? And that's always a very nuanced conversation, because it is genetic in the sense that we identified many genes that are associated with myelofibrosis, but it's not exactly inherited in the strictest sense, like that you're born with myelofibrosis. We look at it as an acquired disease. You acquire the mutations in the stem cells and progenitor cells in the bone marrow that give rise to the disease in your lifetime, but we don't always know why people acquire those mutations and what the perfect storm is to acquire those mutations to develop the disease. We think that mutations are acquired early on in life, and then it takes decades often for the disease to actually become clinically obvious. And although there's an increased risk for first-degree relatives who have myelofibrosis, or an MPN to have relatives that will have a related MPN, it's still a minority of people that are going to develop it worldwide, but also even within someone's family. So although the increased risk may be there, and there may be an inherited predisposition to acquiring the disease, you are not going to give myelofibrosis or related MPNs to your kids in that strict inherited sense, because that obviously is a very stressful sort of thought and concern for a lot of folks out there that are worried about their kids and their grandkids and their other relatives. Myelofibrosis is a disease that doesn't present in a uniform way. Sometimes patients will come to our attention because they have symptoms that are very protean, meaning very general, shortness of breath or fatigue, and they're found to have anemia, and then they get worked up, and things that are common like iron deficiency or B12 deficiency are ruled out, and eventually a bone marrow biopsy is performed and the diagnosis is confirmed. Sometimes patients come to us because they have abdominal complaints, maybe left upper quadrant pressure of their abdomen, or difficulty eating, early satiety, and imaging is obtained and they're noticed to have a big spleen, and then a workup for lymphoma might occur, and it's not lymphoma, it turns out to be myelofibrosis on a bone marrow biopsy. And sometimes patients come into us right off the bat quite ill with fevers, night sweats, spleen-related complaints, low blood counts, and sometimes they show up in the ER like that. Sometimes they show up in the ER with thromboses, so clots in their abdomen, for example. Sometimes they've had an antecedent diagnosis of essential thrombocythemia or polycythemia vera that progresses to myelofibrosis. So there are many different ways in which patients present, and different avenues in which they come to our attention, whether it's through the hospital, the emergency room, or through referral from a primary care physician or another hematologist or a cardiologist or a gastroenterologist. But at the end of the day, these diseases are treated by hematologists, and ideally, when available, you want to really get into the care either directly or indirectly and co-manage with someone who has a lot of experience treating these diseases, because I do think that with that experience comes a certain degree of expertise that can't really be learned on a textbook or in a lecture. It really comes from experience of seeing enough patients with myelofibrosis and understanding these nuances and these variabilities that we see in patients. So at least once, if not on an ongoing basis, consultation with an expert, someone who is recognized as experienced in these diseases, because these are rare diseases, and rare disease by the NCI is less than 4 people per 100,000 new cases. And myelofibrosis is probably 1 new case per 100,000. If you canvass, generalists, general hemonc docs and docs in the community setting, they might have somewhere between 1 to 5, patients with myelofibrosis in their care. And depending on the setup of the group, some groups, maybe one hematologist will be the go-to person for the myelofibrosis patients. But if you go to a center of excellence, that jumps significantly to 50 to 100 to 200 patients. So it's exponential in experience and understanding that I think makes the treatment plans more evidence-based and rational, and that's important when you're dealing again with rare diseases. So I don't know, and if I should pause and
Yeah, I mean, you've said a couple of things that resonated with me, having been in this space for so long and hearing from patients for so long. And one of them was that, the age thing, so, usually 60 plus, you see more patients, probably 60 and over. But there are definitely cohorts of patients that are younger, and we're seeing more and more younger people being diagnosed with all the 3 MPNs that we focus on. So, but I also liked what you said about, the sad thing is not all patients have the wherewithal to get to a MPN specialist. And that's why my goal in this business was always to bring the mountain to the people, and so we try very hard. If you are a person who does not have the wherewithal to communicate with an MPN specialist, to let us know, because sometimes we can have your local hematologist and the MPN specialist have a conversation sometimes, and that does happen, and we're happy to help facilitate that. But you said so many things, and I'm hard to remember, but we'll go to these questions. We have many questions from those that are on this webinar right now. And one is, John, have you seen any patients with CLL, which, by the way, my brother was just diagnosed with CLL, and also MF? If so, how do you typically treat that patient?
So the answer is absolutely yes. So I think it's important to remember that these are, as we've been saying, diseases of the, I won't say elderly, it sounds so so nasty to say,
Thanks.
but of the older patient population. And so increasingly we see CLL and we see MPNs in older people. And it is not impossible to see both entities. If you remember from my introductory remarks, there's the MPNs from the myeloid compartment of the bone marrow.
Yeah.
CLL comes from the lymphoid compartment of the bone marrow. So for the two to exist is not outside the realm of possibility and statistics. And so I do have a number of patients, and I've cared for a number of patients over the years that have both CLL and MF. What's I think also important for people to realize is that CLL is more common than MF, I should point out, and that many people walk around with CLL and don't need to be treated for CLL. So usually with MF, for the most part, most patients are requiring some sort of intervention. Maybe not immediately, most often, very shortly, but eventually patients will. With CLL, it tends to be, in many patients, a very indolent disease that you really only treat when it starts to cause problems like anemia or an elevated white count or low platelets or a big spleen. So the trick and the complexity when you have both is sometimes understanding which disease is driving the anemia, the thrombocytopenia, the low platelet, or the big spleen. That is definitely where you want to get someone who understands CLL and someone who understands MPN to be on the same page. So I often will co-manage these folks with colleagues in New York City that are CLL experts that I've shared patients with over the years. So we have a certain dynamic. And what's I think really interesting for me from a practitioner standpoint and someone who's interested in the biology and advancing new therapies, but also important for patients to understand is there is some overlap in some of the drugs that can be applied for both diseases. So for example, a drug class that has become very popular in treating CLL patients, it didn't exist Like when I first started my career in the mid 90s, I was in a lab at Cornell researching CLL, and none of these things exist. They gave chemotherapy at that time. Now a lot of therapies, or most of the therapies, have switched to oral formulations of targeted therapies for CLL and for MPNs, and even in leukemias, we're moving in that direction. And in CLL, there's a class of agents called BTK inhibitors, which stands for Bruton tyrosine kinase inhibitors. And these are inhibitors that inhibit signaling pathways that drive the CLL cells. Well, it turns out that inhibiting this similar pathway in myeloid diseases like myelofibrosis can also have beneficial effects. And there are now clinical trials evaluating BTK inhibitor. There's one in particular called TL895 that has rationale and already has some early clinical data for benefit in myelofibrosis. So there is, within the armamentarium, there are some overlap drugs, I'll call them, where they could be used in both diseases. So you really want someone who understands both diseases to work together as a team to help you with those two diseases. But many times the CLL could be just left alone.
I'm so happy to hear that personally, and my brother is older and was just diagnosed with CLL, but this was a question from an MF patient, I think. But all right, what is the indicative longest term data on MF patients who had responded very positively to clinical trial drugs early and for a few years?
So if I interpret that question correctly,
Yeah.
I think the question is asking if one were to look back at clinical trial data of drugs that have been tested, what is the longest follow-up for those
Yeah, I
drugs?
think that's what they're in. Yeah.
Well, so I'll try to answer in two ways. So probably the longest follow-up we have of clinical trial evaluation that then moved into commercial availabilities with ruxolitinib or Jakafi, which way back when was a clinical trial drug, and now is a very well vetted commercial drug. That's probably where we have the most long-term experience with an agent. Everything else that we use, is shorter than 10 years. And a lot of the drugs that are under clinical trial evaluation right now are, have median exposures probably measured on the order of several years. So although many of these drugs have been in testing for quite some time, if you were to ask the question, well, what's the longest follow-up for these drugs in given patients, it's less than 10 years for most of these drugs. So we don't have decades worth of, tons of patient follow-up.
Yeah.
What we do have is a general sense that most of the drugs that we're talking about and that are moving, progressing into phase 3 or approved drugs have a ratio of benefit that outweighs the toxicity that can be seen with some of these drugs. And that's the important part. These drugs, none of these drugs, any of the JAK inhibitors or any of the drugs that we may talk about today, like pelabresib, the BET inhibitor, navitoclax, the BCL2 inhibitor, and imetelstat, the telomerase inhibitor, none of them have clean toxicity profiles. They all have the potential, and I want to stress that word potential because none of it's given that every patient's going to experience all of these toxicities, but they have the potential for additive toxicity, whether it's lowering of blood counts, maybe some GI tox, maybe nausea, diarrhea. Usually these toxicities are considered low grade, that means grade 1 or 2, usually early on in the treatment and often manageable and rarely lead to discontinuation of the trial. We haven't really seen toxicities that I'm aware of any of the drugs that would outweigh that benefit to risk balance in terms of later term toxicities of cancers growing out or major infectious issues. Like for example, with Jakafi, we now know after years of following patients and a substantial amount of data, fantastic drug, very effective in addressing spleen and symptom, but there's probably a 5% risk associated with infection. And for most patients, that's in the form of an upper respiratory infection, a urinary tract infection, maybe a lower, like pneumonia type infection. And that's obviously not in every patient. It can be in a small subset of patients, but we think that might be due to some immunosuppressive effects of the drug. Did we really totally understand that early on in the development? No, I think that grew with understanding of both mechanistically what the drug does, but also with cumulative data. So, it incumbent upon us as physicians and the FDA as a regulatory body that we collect all this data, so we are always sort of dynamically measuring, like, does the benefit continue to outweigh the risk with any given drug?
Perfect. And to your point about the wait and watch, what would be the typical amount of time a person in their late 60s with MF2, low medium risk, and mild symptoms remains in the watch and wait phase before needing to start medication?
That's a great question. It's
Yeah.
also a very nuanced question that's very patient specific. So I'll repeat something I said before. Everything I'm saying is really addressing, let's see, like 100 people on this call, and it's not to be taken as direct, medical advice to any given person who's posing that question or thinking about it for themselves, because you really want to understand with your physician, like, what is the goal of treatment for not 100 people with MF, but for me? What am I trying to accomplish with intervention? One of the things I learned very early on is that patients tend to be more symptomatic than they realize. And what I mean by that is often when you start introducing treatments like, let's say, Jakafi, and you start reducing the inflammation that drives the symptom burden, patients will realize how symptomatic they had become, but they had adjusted to it and that was their new normal. And sometimes people will minimize, even to themselves, their own symptoms. Sometimes people will work through and adapt. A famous discussion that I've had with patients, and I make it a joke, but it really is a discussion, is patients, I'll ask patients, are you feeling weak and tired? Are you getting short of breath? And they'll say, no, I'm kind of doing everything that I normally do or that I want to do. I said, well, can you get upstairs? Or do you feel short of breath? No, I don't feel short of breath. I said, well, when you took the stairs up to the cancer center today, did you get short of breath? And say, well, no, I didn't take the stairs. I said, why didn't you take the stairs? Because I would get short of breath. So, people don't realize that they are adapting
Yeah.
to and living a life because of those symptoms, and it starts to cramp their life and corner them in. So sometimes the intervention to address symptoms is not just to make someone feel better. It actually opens up their life, and people who have a more open life in terms of activities, engagement, social work, whatever it is, will globally do, I fundamentally believe, will do better than people whose lives start getting narrower and narrower because they are unable to do as much as they can. So there's a lot of benefit to feeling better. Also, there's a lot of biologic evidence that reducing inflammation with JAK inhibitors or with other drugs that influence the inflammatory cues that drive the disease likely improves outcomes and reduces complications. I think the decision to intervene is based on risk score, as this patient pointed out, their risk score. So usually higher risk patients, intermediate and high risk patients are patients we think are those patients who should be considering treatment. And usually treatment is a first line as a JAK inhibitor. But I would even take someone who's got low risk and has symptoms and consider treatment and weigh the positives and negatives. Because there is some data that would suggest that the earlier one starts treatment, the higher the likelihood that they will have a more enduring benefit from that treatment. And if you think about it just from its simplest standpoint, that makes sense. There are very few, other than CLL, which we talked about, which actually kind of falls in the long line, there are really very few cancers I can think of where we adopt let's wait and see what happens approach. That's not always the best approach, because as the disease moves on, and I don't mean within a week, but over time, months and years, you have evolution, what we call clonal evolution of disease. The disease biology changes, mutations and what are called epigenetic alterations will accumulate, and that will fundamentally change the way the disease is behaving, but also the potential to respond to treatments like JAK inhibitors. So, I think the discussion should be really tailored and personalized for that individual patient, understanding what are we trying to achieve with intervention, and what are the potential toxicities of that intervention? Does it make sense?
Excellent point, because we hear all the time, of course, from women that say, I'm having night sweats and this, but I don't know if it's menopause, I don't know if it's something else, and are afraid to even mention it to their physicians. And, bone pain, there's so many symptoms that you make an excellent point that some patients don't even realize that it is a symptom of their MPN. And so moving on, can you speak to the MF transformed from PV or ET, if they look any different than those diagnosed with primary ET?
That
I'm
question,
not sure I understand
yeah,
it.
that question is, could be a little tricky.
Yeah, so I'm assuming that, can you speak to MF? So if a person um, has ET or PV, what does the diagnosis look like? How is it different when they transform to MF or they convert to MF? I
Yeah.
think that's the question.
I think, and that question would make sense to ask because there is a sense that there's a spectrum of myelofibrosis patients that range from the proliferative on one side to the what we call the cytopenic on the
Right.
other side. And typically those patients who had ET and PV that progress fall on the proliferative side of the spectrum. In general, and again, I'm going to stress the word general because it's not always true for everybody, but in general, those patients with the proliferative form of disease, often ET and PV progress to MF, tend to have less of the low blood counts that typify the cytopenic side of things. They tend to have less of the mutational complexity that the primary myelofibrosis has on the cytopenic side of things, and they tend to have better survival outcomes in patients who have primary myelofibrosis. So although there's clear overlap in the biology and the features in the bone marrow, in fact, I would argue if you didn't give a hematopath, even a really great one, any history and just showed them slides and said, is this primary myelofibrosis or ET, PV-related myelofibrosis? I don't think they reliably can tell you the difference. So morphologically, what it looks like under the microscope is pretty indistinguishable. I think a time will come when we will use machine learning and artificial intelligence to be able to discern those differences, and they may or may not help us, but a human cannot really do it at this point. So there is a lot of overlap, but biologically there are some distinctions, and clinically we do think that they do behave differently. So they're not totally the same, and for that reason, we use risk stratification tools that are primary myelofibrosis derived for PMF patients. So the IPS, the DIPS, the MIPS, the GIPS. I'm always shocked how many patients know their MIPS score all the time.
I know,
But those
but
are
they're,
really
yeah,
for PMF patients. If you wanted to do it for a ET or PV, one should really use the MySEC, MySEC. And the beautiful thing is these are all online. You don't even need to rely on your physician or NP. You can just plug your numbers in, with all the caveats I've listed before. Those risk scores I think are often not interpreted and appreciated by the patient and the physician. A lot of times I get patients that will read that and they'll say, oh my God, my median survival is, my survival is a year and a half. And that is not what those risk scores are telling you. They're telling you in groups of patients, the 50th person in that group, in an era that may not include the therapies that we have now, lived a year and a half. But that does not tell you as the patient that, your life is gonna end in 16 to 18 months. It doesn't work that way. So
right.
be very careful, don't overread those risk scoring systems. They're just general guides to help some treatment decision, but they do not inform you about your lifespan, not accurately.
No. What are the main differences between primary and secondary MF in terms of treatment and prognosis?
So treatment, I would argue, there's very little difference in terms of treatment. Maybe one nuanced difference is the primary MF patients tend to have more of the cytopenias, the low blood counts, the anemia and the thrombocythemia. So for those patients, they may be more inclined to or more likely to benefit from alternative JAK inhibitors. So alternative to ruxolitinib and fedratinib, which are excellent drugs, but drugs like pacritinib and momelotinib that may have less myelosuppression and have mechanisms that are built in. So they're not just JAK2 inhibitors, they're kind of dirty molecules. They inhibit a lot of different pathways that could be important to the disease. So for example, pacritinib and momelotinib inhibit something called ACVR1, and that affects the expression of a protein called hepcidin. And hepcidin regulates iron availability for red blood cell production. So those drugs can reduce hepcidin and provide better access for red cell production to iron, so you can get improvements in hemoglobin. So there are definite distinctions and differences that might tailor the JAK inhibitor treatment that may lead into differences between primary myelofibrosis and secondary myelofibrosis. Outside of that, for clinical trial enrollment, for example, we don't discriminate. We don't say, oh, PMF, you can go here, PVET, we can go there. We include all those patients in the trials. And many of the trials actually do try to analyze, at the end of the day, it's called stratification, whether there are differences in outcomes based on whether you have primary or secondary MF.
Mhm.
But as I said, the prognosis can differ between the two groups too,
Right.
because the disease biology is inherently different.
Okay, so I'm going to try to um, decrease the number of things in this question, but my husband had ET for 15 years and 5 years ago was diagnosed with MF, JAK2 gene mutation and CXSL. He was told that the only cure would be a stem cell transplant, which we all know that is the only cure that if it works for some people. And his physician seemed to recommend that, but he's experiencing no symptoms whatsoever. And I mean, to his knowledge, and he's working out, golfing, swimming, no symptoms, but he's about to turn 70. So we know, I think the cutoff now is 70 years of age for stem cell transplants, or have they raised that?
Well, I think it depends. It's a moving target. When I was younger, 70 seemed so old, and now as I've gotten older, 70 doesn't seem so old. And I think the medical community has also recognized that these are numbers, and they don't always perfectly
Yeah,
reflect the actual reason why we say, oh, cut off. When I
right.
first started doing this, 65, you go over 65, no one got a transplant. Then, we started doing 68-year-olds, 70-year-olds. I've had 73, very rigorous 73-year-olds go through transplant. I even had a 75-year-old that was really very vibrant and very healthy without a lot of competing comorbidities. So I think it's not just the age, it's how much other disease burden does the patient have.
Yeah. He
Um,
has nothing else. He has no comorbidities. And so, yeah, that's the question. Do we do this now and take that advice even though he's feeling great, or,
well,
do we wait?
I think again, that's a very challenging discussion because if one waits too long, then that takes that option off the table.
Yeah.
But for some people, that might be fine because some people might say, "I will never do a transplant." But if one were to be inclined to do a transplant, there's a saying that I think is true. There's never a better time than right now because as you get older and things, it gets harder to do a transplant and more complicated. So, feeling well and being active actually is a good prognostic, measure for outcome success with transplant. So I think that becomes a personal decision. It also depends on the donor. The donor source and availability, might influence that decision making and the resources of that patient. Does that patient, and it sounds like in this case the answer is yes, but does that patient have family and support to help them post-transplant? Because the hardest time, in my opinion, is not the 30 days in the hospital. That's a frustrating time and frightening time, but the hardest time is often after the transplant. There's a lot of follow-up, there's a lot of change in medication, and it's very helpful to have loved ones around you to support you through that. I wouldn't want to ever minimize that importance
Right.
of support. And you got to be transplanted in a center that has experience transplanting myelofibrosis.
Absolutely.
Not
Absolutely.
not the first time they're trying it out and you're going to be their first go at it.
Right. And we have lots of success stories with transplants, lots, many of which were at Mount Sinai. But it's really exactly what Dr. Mascarenhas said. It's very personal and collective at the same time, with your physicians and your family. And to have the family support, we've heard so much from so many patients that have who are not patients anymore, but that was very much a key factor into their success, I think. So this gentleman is 75 years old, had PCV more than 25 years, and was diagnosed with MF almost 3 years ago, and started 20 milligrams of Jakafi twice daily. He's had no symptoms and is very physically active. Is it typical to be symptom-free this long, or am I just fortunate? Am I great? Should I be grateful, or should I wait for the other shoe to drop?
Yeah. Well, I mean, I think we all probably should learn to be more grateful in life. But yes, I think the story sounds like a story that I've heard many times before. Jakafi or ruxolitinib is really, I probably can't think of a better drug that I'm aware of in blood cancer therapy that is as good of a feel-good drug as Jakafi. It tends to really take that symptom burden and really either lower it significantly or remove it completely. The reality is though that if you look at the follow-up of patients on Jakafi, by about 3 years, half the patients on Jakafi have had to discontinue either due to worsening blood counts, progressive disease, maybe bigger spleen, worsening symptoms, what I call symptom creep, it starts to come back, or in some cases, frank transformation to an acute leukemia. So it is a great drug. Unfortunately, those effects are not enduring for the rest of the life for many patients. They will have to move on to different therapies. But again, everyone is different, and I've had patients who've been on Jakafi for well over a decade enjoying the success of that drug. And our goal as a investigative community is, how do we improve upon that? How do we build upon that success by either adding in drugs that are informed by science and synergistic with Jakafi up front, or on the back end to try to salvage the response if one's losing a response. So there's a lot of emphasis on how to capitalize on Jakafi's success and get deeper, more enduring responses. But I would consider yourself, part of those folks that are lucky to have such a nice response. But I also totally appreciate the term waiting for the shoe to drop. I would say most people with, chronic diseases, but myelofibrosis and specifically any TPV, often live with a very frustrating sense of, waiting for the shoe to drop, which is a very frustrating and anxiety-provoking way to live, because you don't know, and patients will come in, and I can see it in their faces, and I understand it. Half the time, they're not really that interested in talking to me. They want to know what their numbers are, because that is like a key to what are things changing, because we do put a lot of emphasis, sometimes too much emphasis, on the numbers. So people do live in the state of uncertainty, like what will my week look like? Sometimes some days are good, other days are bad, and how do you plan your life, your social engagements, doing things that are important with your spouse or your kids, traveling. It has a huge impact. And then the anxiety of what will my situation be, in 6 months or a year from now? It is difficult to live with these diseases. And I mean, that's why we're very dedicated to trying to develop therapies that are disease modifying, that allow us, you as a patient, us as the prescribers, confidence that we're really changing the disease in a meaningful way.
Which is a nice segue into the next question, because we're always looking for drugs that have a molecular change, that changes the disease or stops it or slows it down. This person has started Pegasys and is wondering if it is capable of reversing myelofibrosis.
So most of the data we have with interferon alphas, whether it's Pegasys or ropeg interferon, is really in the ET and PV, particularly PV setting. It's approved for PV. I suspect it will soon be approved for ET based on the SURPASS study. That's ropeg interferon alpha 2B or besremi. Excellent drugs with probably the best evidence to date that these work on the stem cells, the malignant stem cells, and they have the potential to even induce molecular remissions in about a quarter of the patients that are treated with the disease. So I am a believer in interferon. I don't think it's a panacea for everybody, but I do think it's a drug that has its place, and sometimes that place is colored by the toxicities that can sometimes occur with the drug. In myelofibrosis, it's a little bit less clear in my mind, the full impact of interferon. There is some data, earlier data, that it can be used, I think to a lesser extent in terms of disease modification and regression of fibrosis and perhaps more toxicity. But there are a subset of patients that can have a response to interferon, even in the myelofibrosis stage of their disease. But if you were to ask me when is the best time to intervene with interferon, I would say before someone develops myelofibrosis. There are some interesting looks at treating myelofibrosis with interferon and Jakafi, combining the two agents in a collaborative way to work on those abnormal stem cells and inflammatory pathways. And there is some data for interferon and myelofibrosis, but I do think that the biology of the disease in myelofibrosis may be such that drugs like interferon, which are just laboratory forms of a signaling molecule that is important in the immune system functioning, may not be as effective as when you use them earlier on in the ET and PV stage of the disease.
So what about the other JAK inhibitors that are approved by the FDA currently, like momelotinib? Would you say that, I mean, there are obviously patients that aren't doing extraordinarily well on Jakafi, and we now have the choice. Are you seeing the same results with momelotinib?
I think the advantage we have in 2024 is that we have the ability to treat niches that we couldn't treat effectively with Jakafi before, and we have the ability to sequence JAK inhibitors that didn't exist before. So ruxolitinib or Jakafi 2011 was approved, really set the standard of care for like nearly a decade. 2019 is when fedratinib or Inrebic was approved and provided us with an additional JAK inhibitor if ruxolitinib was not effective particularly, and the spleen was quite enlarged. I have found Inrebic to be quite effective, but you have to know how to use Inrebic, and a lot of times it's not used correctly, and I think the full benefit is not realized. And then Vonjo was approved in March of 2022, and then most recently, end of October, momelotinib or Ojjaara was approved. Pacritinib or Vonjo is a perfect drug for those patients that have this very extreme form of cytopenic myelofibrosis typified by a platelet count that's less than 50,000, but I would use even less than 100,000, and has effects on anemia. Ojjaara was a drug that was approved off the MOMENTUM study with some data from earlier studies called the SIMPLIFY studies that took patients after ruxolitinib exposure and had unmet symptom burden and anemia. And it's a drug that can stabilize the hemoglobin or even improve the anemia in some patients while adjusting or addressing spleen and symptoms. So I think they're all great drugs, actually. I think we're lucky to have all four of them. I have nothing negative to say about any of those drugs. I see them as all positive additions to the armamentarium and allows us to implement some art into the science in terms of crafting the best initial approach and maybe sequencing based on response or lack of response with the initial drug. But I unfortunately, as much as I love all four of these drugs and think that they all have their place, none of these drugs are remitting the disease, and that's important for the folks that are listening to understand. Is these are great drugs that clearly improve many facets of the disease, but we're not curing patients with disease. We're not remitting the disease in a meaningful way, and that's where the clinical investigation is moving forward into.
So two things that every patient wants to know, and well, for sure this one, and that is progression. And we have a huge cohort of young patients that we are in communication with pretty regularly. And young meaning teenagers and in first and second year in college. And so I would say 15 to 30 maybe. And those patients particularly are a little concerned about progression. Are they going to live to their 60s or 70s? And I mean, I always assure them that they most likely will, and that there's so much research and so many things in clinical trials right now. But what would you say to those patients?
Well, I can appreciate if you're younger and diagnosed with these diseases, you have more time in your life to experience complications and progression of disease. So that would be a natural worry and concern that I would have if I was in their place, or as a parent I would have for my child is what will their future be long, and what to expect. How do we optimize them for that future? I think there's a lot of very exciting and very meaningful work that's taking place both in the laboratory and translating into the clinic that and you've had me on this program many times before, and so you'll know that I say this and I mean it with utmost honesty. I do genuinely believe that the work we do today will benefit those in the near future, and I don't mean like distant future 200 years
No,
from now,
I agree.
but in the near future. Right? I've seen it already, and it will just continue to grow. It just continues to need more effort and more work. It continues to need more buy-in from patients too. I'll point out, like the participation of brave people, who take chances and get involved in clinical trials, which ultimately I do think benefit patients, is what moves the field forward. And we have been fortunate to have these 4 approved drugs. We need to do better, and that's really where clinical trials becomes important, because the science leads the trials and leads the drugs that then enter the trials and the combinations that make the most amount of sense, with the idea to try to really change the disease. And I'm uninterested in drugs that just modify aspects of the disease that don't have meaningful impact, not in 2024. So, you know, we here, and I don't mean just us exclusively, but we in the greater we sense, I think, but specifically myself and my colleagues here are really genuinely committed to understanding the disease mechanisms at the level of these stem cells that are causing the problems, and how best to exploit that for therapeutic gain, and gain in the most deepest sense, to try to ultimately cure these diseases with options that don't include transplants. I mean, nothing would make me feel happier than to put my transplant colleagues out of business and have drugs that really are meaningfully impactful to the disease course. I do think that we're moving in that direction. I do think that the focus needs to remain there, that the funding from the government continues for groups like our research consortium, which is an NCI-sponsored grant in which Ron Hoffman is the lead on, and myself and Ruben Mesa and others are active participants in trying to rapidly take these laboratory insights and transform them into clinical studies that will move the field forward. And usually these are incremental moves. They're not always transformative, but they add up, and they eventually help patients across the board.
And I'm glad you brought up clinical trials. There is a question here, and we are every other month we we actually create a clinical trials and science update. And this question is, can you talk about the clinical trials for the monoclonal antibodies that have started? Yeah, that would be great.
So one of the trials that's gotten a lot of interest, I'm personally excited by it, because I think it is a step in the right direction, is a study that Insight has really driven forward by developing an antibody, which is basically a protein that can tag the mutant calreticulin protein on the surface of cells. So this part of the discussion right now is pertinent to the 25% of patients with myelofibrosis that are driven by mutant CALR as opposed to JAK2 mutation or MPL mutation. And again, most patients will know what their driver mutation is, or can find out from their physician based on the studies that were done when they were diagnosed. If you have mutant CALR disease, you may be a patient who would be eligible for the mutant CALR antibody approach, which is currently in phase 1 testing here in the US and in multiple countries, including Australia and Japan, outside of the US. And this is an antibody, very simple, it's very elegant really. It's an antibody or a protein. It doesn't deliver a payload, so there's no toxins associated with it, and it basically connects to the mutant CALR protein that's aberrantly expressed on the surface of the cell, in conjunction with the thrombopoietin receptor, which is an important signaling receptor. And that has the ability in the lab to turn off those cells and to allow them to die, a process called apoptosis. And in mice, we use mice a lot, and we engineer them to try to mimic a myelofibrosis disease phenotype that we'd see in humans, and then we're able to understand the biology and even test therapeutics in these mice models or mouse models. And in modeling, this approach really seems to be quite effective and has the potential to even get to the base of the disease, the stem cell population. So we are now testing that in a phase 1 dose escalation. I would anticipate minimal toxicity, but of course, no one cares what I anticipate. We have to do the studies and be very rigorous about them to make sure that we're ensuring safety and appropriate observation. But I'm very hopeful that this type of immune-based therapy will be transformative in patients with mutant CALR. There are similar approaches that I just want to mention, like vaccine approaches, which really invigorate your immune system to go after the mutant CALR bearing cells. So it's another angle, the same theme. There are what BiTE antibodies that some of the companies are developing, which are bispecific antibodies. So they connect your CALR mutant cells to what are called T cells, which are immune cells that then go after and kill the CALR mutant cells. So it's really a new era of harnessing your immune system, which is not doing the job it should. It should recognize these cells as abnormal, get rid of them, and helping them understand and invigorate them to get back to business and to create immune responses to the disease. We all develop cancers every day, actually. That's the sad truth of it. But the reality is that our immune systems, for the most part, are able to recognize and get rid of those cancers and keep them in check. So there is a concept that there is a certain lack of immune understanding, surveillance, and capability in patients with cancers, and that we have to help them with either what are called checkpoint inhibitors or other ways of trying to get their immune system revved up to do what it should be doing. So I like that approach because it's not directly targeting the disease, it's sort of indirectly targeting the disease. So I'm very bullish on that approach.
I agree. And I love that you have been bringing me to the next question, or to the next thought process here. And that is, we've talked over and over again about, that we all, the switch could go on, and here we are. And there are, we've talked about indicators or things that we can do, in terms of stress. My brother, for example, who was just diagnosed with CLL, was under a tremendous amount of stress prior to his diagnosis. And, we are all thinking that was something that maybe, helped turn that switch on. But so we have started, having yoga classes online and some other things. We're bringing a nutritionist in to talk to our patients and so on. But, do you suggest that, or do you have those conversations with your MPN patients, John?
Yeah, probably not enough. I have grown as I've gotten older, and appreciate that age is a number. I've also recognized the importance of not just diet and exercise and sleep, which is totally undervalued. And is critical to well-being and health, and multiple studies have shown that. But there is a true power to meditation and prayer that I think many people miss out on, and are great adjunctives to optimizing their care, maybe even preventing worsening of disease. So I'm a big fan of and proponent of these modalities, which have very little to no risk associated with them, but have absolute potential for benefit. Unfortunately, I can't say that they would take the place of modern therapeutics. They definitely can be used with these treatments in order to optimize patients. And I do think that patients always say to me, well, I went through a very stressful period in my life, and I think that's how I developed the disease. And there may be some truth in that. I don't want patients to ever live with regret that they caused their own disease. That's not helpful nor healthy. And I don't think it's as simple as that. But I do think that there are changes in inflammation in stressful situations that might be able to just move the doors apart just enough to allow things to escape. And so there may be some aspect of that that's there. And anything that can reduce stress, that can help bring calmness to someone's life while thinking about the things that are important that mothers have been telling kids for generations, which is a healthy diet. I wish there was like a specific food that I could say would dramatically change your MF diagnosis, but I think healthy diets and Mediterranean diets, exercise, sleep, meditation, yoga are all 100% an important component to the care.
And even in New York City, if you're here from New York City, although I know we have people here from all over the world, but if there is one place you can go to, a park or I love Central Park, and any place where there's green space where you can just sit and be peaceful for an hour, half hour. If you can walk to your mailbox and walk back a couple times, I mean, anything that gets you moving. We have a little program that I started, but have got to add more recipes to this diet. I'll go with the flow. And it's all about a Mediterranean diet and different recipes. And so that may be useful, but there are other things out there as well. So John, in closing from you, my dear, what wisdom would you impart to the patients that are on this webinar with us today, but it's also recorded, and so many more will be viewing this over the next few weeks and months. What wisdom would you impart to MF patients today?
Maybe the only thing I can say that's even remotely wise is that you are, you're not alone. These are rare diseases, but you can see from this webinar, if there's 100 people on this call, then you recognize you're not alone. And that although you're not alone and you have a diagnosis, you are unique at the same time. So really the care needs to be tailored and personalized to you. Don't just do what you heard someone else do because someone on a webinar said that. Really seek the care and the expertise that's based on your disease features, your molecular profile, your life, and your expectations with someone who really does this full time and is dedicated to it. And the last thing I would say is there remains, I've been saying this for years and it still is true, there remains an intense amount of focus and collaboration, most importantly collaboration, and not working in silos. And I'm a major proponent of that, whether it's foundations like Ann's or centers that are pooling resources, the government that's funding this, philanthropy that bridges the gap, and then big pharma that comes in with the drugs. We need to work together, and that's happening. And we need to listen to the scientists in the labs that help reveal the biology that then informs the treatment decisions and the steps for success in the future. That's happening. I know it probably feels very slow to those on the webinar, but this is day in and day out that people like myself are dedicated to doing this. And I remain confident and optimistic that we are getting somewhere and that we will continue to work on your behalf and with you guys.
I totally agree. I totally agree, 100,000%, that we can't do this alone. And I use this term a lot as other people have over the years, and that is it does take a community, and the MPN community is amazing. It is just amazing. And more physicians are focusing on MPNs, which is fantastic.
Yep.
The event we're hosting in North Carolina with Dr. Massa in August, there are several new or different physicians, MPN specialists, that we're hearing from for the first time. And I just got an email this morning from somebody in Richmond, Virginia, and who is a female who is doing clinical trials and focusing on MPNs. So for those that have been with us for a while, like John at Mount Sinai and Dr. Hoffman at Mount Sinai and others, it's been a beautiful experience for me, bar none. And, having been in breast cancer and prostate cancer, wasn't like this at all. So the fact that there's collaboration, there is collegiality between these groups of physicians is fantastic. So I will thank you. We're going to stay on for a little longer and get some updates from a few of our industry partners. But John, I can't thank you enough. Thank you so much.
My pleasure. Thanks for having me.
Have a good day. And so now we'll move on to our industry partner updates. We only have a few today. And with us right now is Stephanie Jardine, who is with Insight. She's the oncology clinical nurse educator. Stephanie?
Thank you, Anne, and thank you. I'm very pleased to be here today to represent Insight, and I would like to thank Anne and her group at MPN Advocacy and Education International for giving me a few minutes to speak about our company and our commitment to patients. So Insight is a corporation that is based in Delaware, a biopharmaceutical company, and we are committed to providing better outcomes to patients through medicines we develop and education we provide and our support of the community. One of our most important commitments is to help ensure that appropriate patients may have access to the medicines they need. And for this reason, we have developed a patient support program called Insight Cares to help appropriate patients and healthcare providers access their prescribed medications. And to find out more information about Insight Cares and the different um, things that we offer through Insight Cares, you can access that through www.insight.cares.com. And there you can enroll in Insight Cares, even if you don't think right now you're going to have any assistance problems. Initially, circumstances change over the time of your diagnosis and the disease. And if you enroll early, then we are able to provide more help quickly if that is needed. We also strive to, as we heard today, clinical trials are very, very important. And we are currently enrolling eligible patients in clinical trials for MPNs and myelofibrosis. So if you're interested, please contact your healthcare provider. And there is also more detailed information about the clinical trials that Insight is involved in, as you heard today on this webinar. And you can find that information at www.insightclinicaltrials.com. So again, our company name is spelled INCYTE. We also strive to enhance support in the patient community and to integrate the authentic patient voice throughout all of our initiatives. And partnerships like the one that we do have with MPN Advocacy and Education International have been key in helping our understanding of the unmet patient and caregiver needs, including raising disease awareness, providing educational information, and things like that to the community. We host a website called The Voices of MPNs, and that's at voicesofmpn.com, where we provide access to MPN information, patient stories, access and information to and for MPN community events such as Facebook Live events, patient meetings, podcasts, and also some symptom tracker tools that can help you in following those symptoms. And the last thing I'd like to just talk about is we created a program called MPN Heroes, and that's to publicly recognize individuals who have excelled in caring for patients with an MPN or have advanced the science in MPN to increase awareness and support of that community. And you can actually nominate someone, and the nominations are open, and you can find that on the voicesofmpn.com website, and it's under MPN Heroes. And that nomination period is open until the second week of September. But I'd just like to thank you again. Programs like this allow Insight to use our resources to help improve lives of individuals most impacted by the diseases in which we work. So thank you, Anne, and your group for
Thanks,
this
Stephanie.
today.
Appreciate the update. Thank you. And now we'll hear from Elvie Gonzalez, who is the Patient Engagement Liaison at GSK. Are you with us, Elvie?
Yes, I'm here. Thank you. And probably I will stay off camera since my internet connection is not very stable. So, but good afternoon, everyone. Thank you for allowing me the opportunity to speak with you today. My name is Elvie Gonzalez, and I am a patient engagement liaison with GSK Oncology. GSK is a global biopharma company with a purpose to unite science, technology, and talent to get ahead of disease together. GSK is focused on maximizing patient survival through transformational medicine. On September 15, 2023, as Dr. John mentioned, GSK announced that the US FDA has approved Ojera, momelotinib, for the treatment of intermediate or high-risk myelofibrosis, including primary myelofibrosis or secondary MF, post-polycythemia vera, and post-essential thrombocythemia in adults with anemia. Ojara is a once-a-day oral JAK1, JAK2, and activin A receptor type 1 inhibitor and is approved for both newly diagnosed and previously treated myelofibrosis patients with anemia. Ojjaara has been studied with regards to key manifestations of the disease, namely anemia, constitutional symptoms, and splenomegaly, which is an enlarged spleen. Each person experiences myelofibrosis differently. We talk about today about that, which can make navigating symptoms daunting. Despite increased focus on resources in the past decade, there is a need for a clearer roadmap to help those impacted by MF and their loved ones chart their next steps to better navigate the disease. Mapping Myelofibrosis, a website created by GSK, is an initiative designed to increase awareness of this complex blood cancer, which can be difficult to diagnose, whether you or someone you care for has been living with this disease for years or is experiencing symptoms without a diagnosis. Mapping Myelofibrosis connects the community with educational tools, resources, and stories to help navigate all aspects of the disease and help encourage conversations with your healthcare provider. Mapping Myelofibrosis website can be accessed at www.mappingmf.com. And please just be sure to consult with your physician regarding your care and treatment options. And to close, I just like to add that we are so grateful to MPN and the entire myelofibrosis advocacy community for all the work you are doing to raise awareness, educate patients and their care partners about this disease. We appreciate the partnership and hope you have a wonderful afternoon. Thank you.
Thank you very much for that update. We appreciate it so much. And now we'll hear from Sobi and Leslie Ferber, who's the Associate Director of Advocacy Relations. I know you're with me, Leslie, because I saw you earlier.
Yes, I am here, but it says I cannot start my video.
Oh, dear.
Oh, there we go.
There you are.
I mean, it's probably the right thing for you to not allow me to start my video because, you know, I'm the troublemaker here. I'm just kidding. Thank you, Anne, and thank you all of you for, you know, staying on and just really being here for this really important you know, talk. I learned so much and just love the informed questions that you all kind of brought to the table. You know, so as Anne shared with you, my name is Leslie. I'm the Sobi Advocacy Team Lead for MPNs. Some of you may recall, you know, the term, you know, CTI Biopharma, the maker of pacritinib or Vonjo. This past June, CTI became part of Sobi through an acquisition. So we are a larger company with other approved therapies within the hematology and oncology space, and have you know, resources to support Vonjo as well as the MPN community with more research and programs such as our copay program, which you will find access to at vonjo.com. Sobi's mission is to make innovative care possible for people living with rare and severe diseases. Over the last few years, I just love how, you know, we talk about there's been a lot of advancement in the understanding of the biologies in MPNs and just kind of, you know, resources as well, right? And that includes development and the studying of Vonjo. Vonjo is a unique JAK inhibitor developed for MF patients living with cytopenias, low platelets, and low red blood cells. Vonjo has a unique mechanism of action which differentiated from other JAK inhibitors. Vonjo is JAK1 sparing and targeting JAK2 and IRAK1, all of which are important targets for MF patients living with cytopenias or low platelet levels without causing myelosuppression. We have learned that maintaining JAK1 signaling is essential for platelet production, stem cell activation, and innate immunities. Vonjo potentially offers a dual mechanism for improving of anemia. It's unique It uniquely addresses the underlying biology of cytopenic MF, therefore can improve symptoms, stabilizing platelet counts, and reducing transfusion dependency. As I close, I would love to thank everyone on this call. It is so important to stay knowledgeable of the science as we, really continue to learn more. I love what the doctor said. It's like you're not alone, but you're also unique. So just kind of being here, having the community is super critical. But also, kind of learning the types of MF that you might have, right? And just kind of considering a therapy and treatment that is suited for you is super important. So thank you for allowing me a couple minutes to provide some comments. We are super excited and happy to be able to partner with, with Anne in the MPN Advocacy and Educational International space, and just really kind of making sure the unmet needs and just kind of addressing the psychological, the psychosocial aspect of just having a disorder, because just like Anne said, it takes a village. And I like to, and my term that I like to say, it's like it's a family affair. When you're
Thank
living.
you, Leslie. Thank you very much. That's very nice. So in closing, I just want to let everyone know that tomorrow we'll be talking about PV, and then with Dr. Bose, and on Wednesday, we'll be talking about essential thrombocythemia with Dr. Gabby Hobbs. I hope you'll join us. And then the end of April, April 25th, we will actually be in Grand Rapids, Michigan. If you're in the Michigan area, Illinois, Indiana, let us know. You can register for that event. We have some great speakers coming to that event. And then we will be hosting, I think we have webinars planned through May. So keep in touch. And if you have any other questions, please let us know. Thank you to our patients, to John Mascarenhas, who was excellent, and to our industry partners, which make these all possible. Thank you so much. Have a good week.